Well, welcome everyone, and thank you so much for being with us here on Perspectives with Asima Silva. As always, we are coming to you from downtown Worcester at WCCA TV. And Perspectives is just that. Asima gives us her perspective on the world. And today, well, you may have heard that we are in the midst of a pandemic, so we have got the perfect guest for you. Dr. Khan is joining us. He's an epidemiologist. I'm going to have him describe a little bit about his work at St. Elizabeth's to start us off. We obviously have quite a bit to get to, including the fact that we are now rolling out the vaccine. We have our first responders who are in phase 1 who have been getting the vaccine. And as we are taping this and talking here tonight, we have our second case, and it is a young person in their 20s in Worcester County who has the UK variant of COVID-19. So we'll get a little bit into that, I'm sure, as well. Dr. Khan, welcome.
Thank you so much, and thank you for inviting me to the show. I hope I can lend some perspective on the pandemic. And on COVID-19.
Yeah, and before we get to that, and Asima asks her first question, could you tell us just a little bit about epidemiologist? You really are the man that we want to talk to, what it is that you do.
Well, actually, I wear a number of hats. So the bigger hat that I wear is one of being a cardiologist. I'm actually an interventional cardiologist, but I'm also trained as an epidemiologist, as you were kind of alluding to earlier. I'm a graduate of the Harvard School of Public Health. And, part of epidemiology is kind of the collection of the incidence and the variants of diseases. And COVID has really been a minefield for us to kind of look into, as it were. So this is, has been up my alley. Although most of my work is epidemiology within the field of cardiology. But COVID having come along, having never been here before, right, has, opened up new horizons of knowledge that we did not have previously.
Yeah. And people are always talking about the underlying conditions. We hear so much about that. And we also hear about some of the long haulers and what it does to the heart and to the lungs. What have you been seeing?
Yes, so, I think, you can almost describe, this coronavirus as a systemic disorder. And what I mean by that is not just a virus that causes your nose to run or causes a pneumonia, but causes an infection in the heart. It affects the kidneys and the neurological system as well, in that you lose your sense of smell and taste. It can affect the GI system, where you can have episodes of diarrhea, so on and so forth. So really it can affect most systems within the body. And a lot of people are describing it as a vascular disorder, which again would fit in with the cardiovascular background that I have, in that it seems that there's inflammation of the endothelial lining that leads to the formation of clots within the body. And that often is how people end up dying, with various forms of clots that occur within the lung or within the heart. There also seems to be, an over-amplification of your immune system. And in the people who get that, that's the one that leads to multi-organ disorder and eventually to death. And who will get that and who will not is very, very unpredictable. It's very variable. So when you hear of young people dying, often it's because of that. But oftentimes there are other risk factors that people have that predispose them to this somewhat.
Age, obesity, other
absolutely
underlying
age,
conditions?
obesity, diabetes is a big one, high blood pressure, which again underlines why I think prevention is always better than cure, and the control of these risk factors at any time is an important thing, not only during coronavirus, but I think a healthier lifestyle and controlling diabetes, controlling blood pressure will lead to a longer lifespan and a healthier lifespan in general. But what you touched on is exactly right. Age is the biggest one potentially, but then high blood pressure, diabetes, the presence of coronary disease, and the presence of any chronic obstructive pulmonary disease. So people who have been long-term smokers may be at additional risk as well.
So I have attended many of some of your informational sessions that we have done through another organization, and that's why I'm quiet, because I have asked all these questions to him before. Yeah. And I wanted to have another person who may not have heard your answers. So thank you for coming. But Dr. Faisal Khan, I wanted to say your whole name, so if anybody wants to look you up, they can. But I guess like what I'm mostly interested in is also, how did this start about? We hear a lot of conspiracy stories. We know that it started off in China, but where exactly? Because we've heard that it started off in, through some animals, maybe through, the labs. Was it intentional? Was this something that, what people or think it's a conspiracy theory, that this is a kind of a virus that was man-made purposefully to influence the population and population control, et cetera, et cetera. I just wanted you to shed some light on the history of this virus.
I think it's kind of interesting because this virus has certainly opened our eyes to the fact of the amount of disinformation that can spread, especially in the world that we live in now, with social media and how quickly some of these things kind of spread. But, all of the science suggests that we know that it started in Wuhan. And interestingly, we're at the 1-year anniversary, almost exactly, I think, yesterday, of the first case that was diagnosed in the United States. But just over a year, it was late in 2019 in Wuhan. And I think today was the day that the lockdown was announced in Wuhan 1 year ago. And it appears that, I can say quite categorically that this was not a man-made virus. It was not made in any kind of lab. Where exactly it emerged is not clear. Was it a pangolin? Was it a bat? I think that has not been clarified. Coronaviruses do tend to jump between those kinds of creatures. We know that mink can get infected, as we had in the cases in Denmark. Was it a mink? But it definitely associated with one of those wet markets, as they call. And I think, it really does start to emphasize the fact that we as a human species should perhaps be avoiding those kinds of things and are encroaching on the habitat of a lot of animals. That's a little bit of like how Ebola comes about as well, which has got a much worse mortality. But again, it's that kind of human-animal interface that seems to be creating.
Makes me feel better that I'm a vegetarian.
Yeah.
Yeah, very, very good. The way in which it spread so quickly around the world as well, the way in which we all travel now, and even with this UK variant that we are seeing, and the way in which that is now showing up in Massachusetts or some of these other variants around the country. The precautions that we are taking, and as we're speaking, we're getting ready to roll back, allow the restaurants to be open past 9:30, relax some of the restrictions that we're in. Does it still come down to the masks, to the social distancing, to the wash your hands? And if it does, why after 10 months have we not been able to get a handle on that? Are we not enough of us observing all of the precautions?
I'd say there's two things. There's two kind of pointers to that question. And the first one is, this is a very insidious virus. And what I mean by that is that it can hide itself and travel in ways that you wouldn't imagine. So this is the SARS-CoV-2, as you might know. SARS-CoV-1 was seen earlier, about a decade before. But one of the things with that one was that it had for example, very high mortality rate. So more than 10% of people who contracted that virus died. And essentially, you wouldn't get it from somebody else unless that person had symptoms. And because the hosts were dying, they were getting very, very sick. Here, what's happening is that you can, as you know, you can be asymptomatic, or what we call paucisymptomatic, have very mild symptoms, not even think that you're ill, but be spreading the virus to others without knowing that you're doing that. And as a consequence, the virus spreads a lot more. So that is one factor in the spread. And then the second factor in the spread, unfortunately, is that, George Bernard Shaw said, one of the facts of history is that we don't learn from history. And one thing that we should have learned back in 1918 from the Spanish pandemic when it happened was that, at that time there wasn't a vaccine. They couldn't roll out vaccines like they could now. And it all came down to public health epidemiological measures that were contracted. And the classic example that's given is the difference between St. Louis and Philadelphia. And if you remember, this was the end of the war, and in Philadelphia they wanted to welcome the folks back, and they basically held a parade, and a little bit of it was political as well at the time, that they wanted to be seen to be doing that. And in St. Louis, they closed down the parade. They didn't allow that. And in Philadelphia, the hospitals were overrun within a couple of weeks. There were thousands and thousands of people dead. The mortuaries were overrun, and they didn't have that problem in St. Louis. And unfortunately, the same thing seems to have happened to some extent again today. I guess we as a human species, I said, don't understand or don't change. And unfortunately, a lot of this became politicized. And because of the politicization, I feel that some people didn't buy in to the fact that these public health measures do work, and that this is a real disease. There's still people out there who think that this is some sort of conspiracy theory, that this is overblown, and there are people who I see in my clinic who come to me and say to me, "Oh, you know what? These numbers are being exaggerated. Yep. They're inflated. They're not true. I don't see this happening." But I said to them, "Come upstairs with me. Come and see the people who are sick and dying." It is a reality, and let's not politicize it. For our own sakes, and especially since now this virus can mutate, as we're seeing from what you're saying. We really need to keep our guards up as we get closer to the finish line.
Do you think that now the Biden administration, that we're getting more, it seems to me that not only did we have the politicalization in ways in which we were getting two different messages. What was being said was not what was being on display, so it did lead to, and I had read that even in 1918 they had like anti-mask societies and all kinds, right? And I mean, exactly, so it really is history repeating itself. The Biden administration, 100 days, 100 million vaccines, really being focused on this message of masks in all the federal buildings, all federal employees, asking us as our patriotic duty to put on the masks. Now that we're having more of a federal response, instead of just 50 states, 50 different responses, do you see, or are you already feeling, even though as we're taping this, we're only a couple of days in, do you think that we're going to feel or see a change?
You know what, it's early. So let's hope that it kind of works its way through to the ground level. What I'll say is that the vaccine rollout, from my own observations, has been too slow. And we really hope that it will ramp up. And when I say too slow, I mean, obviously, I've actually been vaccinated as a frontline, first-line responder. I've had both the doses of the vaccine. But even in my hospital, I felt like we really should be getting through this quicker. It shouldn't be like, music is playing in the background, you're walking in, and, they should be like boom, 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 like put next. And that rollout was much slower than I had anticipated, which is why in the country, I think that this is kind of emblematic of what's going on everywhere. There really should be lines outside, people getting in and getting done, as opposed to you having a time that, hey, you got to be here at this time. And when you're not there, hey, are you coming? Are you not coming? It should be, you're here or you're not here. You're going to get this vaccine, and let's get it done. So let's hope that this whole thing begins to change. And I do like this philosophy of let's try and get it into it. Let's release the supply that we have, and let's get it into as many arms as we can and kind of see where we can go. You may know that, in other places, in Europe, for example, in the UK, they've taken a different philosophy, which not everyone agrees with. But what they've done is they've said, hey, look, if you've got the vaccine once, you get up to 80% immunity from Pfizer and, very close to that from the Moderna vaccine. And we're going to delay the second one because we're going to try and get it into as many people as we possibly can because we want to get as much coverage as possible. So, rather than concentrating, because by the time my second opportunity came to get the vaccine, somebody else could have been getting that shot.
As far as gaining herd immunity, though, what is that difference between the 80 and the 95%?
So that's the point they're making.
Yeah,
that's the point that they are making on the public health level. You see, it's interesting. When we started Operation Warp Speed, what they were saying was that, look, the vaccine needs to be better than 50%, which you would hope it is. And actually, a lot of vaccines, this vaccine is amazing that it's getting up to 94% efficacy 7 days after the second dose. We were expecting it to be somewhere around 70%, where traditional vaccines have been, like the AstraZeneca vaccine is coming out around 70%. So you can imagine that if you immunize 70% of the population with a 70% efficacy, you're at 49%.
Right.
Of people of herd immunity. You're at about 49%. It's just simple math. That means half the people are still vulnerable in the population.
So it's not enough.
So it's not enough.
Right.
You need to kind of get upwards of 60, 70%, 80%, 90% people vaccinated. But luckily, because this vaccine is more effective, we're running in the 90% range. Wow. You might be able to attain immunity if you can get more people vaccinated. And that's the approach they're using there. They're saying, well, if we have 80% and we get, let's say, 80% of people, 70% of people vaccinated, we're at 56, 60%, which now is approaching somewhere closer to where we might get with herd immunity.
Can you describe to us, like you said, efficacy of the vaccines, a little bit more in detail of which vaccine is better, why should we trust it, how many people have been tested on it? We have never seen a vaccine come out this fast for another problem, so should we be, a little bit hesitant about getting it? I've heard both sides. I've heard people say, I'm going to wait and see what happens. I don't know the long-term effects. Are my children supposed to get it? What are the developmental effects when a child might get this vaccine? So if you could share a little bit on those various questions I just threw at you.
Yeah. I think those are all kind of excellent questions. We could talk about each for like an hour. The overarching view from the science and from the studies that we've got is that the vaccines are excellent. They're very, very effective. In the Pfizer vaccine, 43,000 people, 22,000 in each arm, where there was no very serious adverse effect, like people dying or anything of that sort. After the vaccine came out, you might have heard of people who got anaphylactic reactions, but those are people who carried EpiPens with them. They were not kind of regular everyday folks. So they have severe allergies to anything, and they ended up with this problem, which is part of the reason why we're now observing everybody for 15 minutes after they get the vaccine to ensure that no sort of anaphylaxis occurs. But I think if you don't carry an EpiPen, that reaction is unlikely to happen. And the other reactions are what you would expect from any vaccine, a sore arm, a headache, a runny nose, some people are getting chills, but those very short-lived. Nothing like you would get if you were to get the real COVID. The AstraZeneca vaccine efficacy is working out. Interesting, it's an interesting kind of study about what happened. It seems like a few thousand people got a dose of the vaccine that was unexpected, as in they got half the dose originally and then the full dose later. And they had a very good response. They had a 90% efficacy, whereas the people who got the full doses twice were around about 60-something%, closer to 70. So it's not clear why that other group, and that's being studied, why did they do better? Was it that the first dose ramped up the immune system just a little or enough that when they got the second dose, it really gave them enough efficacy, whereas you might overwhelm it with the first one? It wasn't completely clear why. But regardless, as I said in the beginning, the line was drawn at you need to have just above 50%. When you're getting 70, that's kind of what the polio vaccine, the MMR, that's kind of the level that they live at, around 70%. And when we talk about that, what we're saying is that 70% of people will mount an immune response. So when they are exposed to the real antigen, they have immunity to it. 30% will not have mounted that immune response. So when they're exposed to it, they'll get sick. But if you have herd immunity, the chance that you will get exposed to it is exceedingly low. You're very likely to go through life and not have that problem. Unless people are not getting the vaccine, like what started happening with MMR.
Yeah, well, and that's a little bit about what you were talking about, too. That is something that is interesting. I am just old enough to remember being at my desk as a grade school student, and they gave you the polio vaccine, and the whole class just drank it. Nobody said, oh, hold on a second, or I'm worried about it. Right, we just all did it, and you figured, oh, well, now, and then everybody, you're talking about 70%. I mean, at the time, we all just assumed, well, it's 100%. Everything is always effective. So it's interesting now how we, even with more information, goes back to what you had talked about with the amount of misinformation. But I think that also sometimes when there is correct information or the media was giving us what they felt was the right information in the beginning, they were telling us that it's going to take 2 years. Most vaccines will take 2 years. This is the way that a vaccine is done. And so what it seems to me kind of got lost was what I've been hearing, where this vaccine was able to come out so quickly because the groundwork has been laid for the last 10 years or more. This is simply how vaccines are made right now. We were able to do it so quickly.
Well, you're exactly right. So the groundwork was there because originally a lot of the groundwork was done for SARS-CoV-1, which we alluded to earlier. But because SARS-CoV-1 kind of petered out much quicker than we had expected, the resources were not put in it to complete it. So some part of that was already in place. The second thing that happened was that, they poured in billions of dollars, which usually doesn't happen. It came from the government. And you've got to give some credit to the administration that went out, that they did put those resources in to ensure that that program was pushed forward, and that those vaccines were developed very, very quickly. And I think that this points to the fact that if you put money into science, you can get very good results very, 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 very rapidly. Now, the other thing that's interesting is that this vaccine, and this is part of the reason there's a little bit of perhaps disinformation. We had been thinking about the body's response to a mRNA type vaccine because actually it had been looked into for fighting cancer. That could you get the body to look at these cancer cells, which are foreign cells, and get your own immune system to fight them off by introducing an mRNA type of thing. That's what BioNTech work was all about. But they had figured out before that this could be something that could be used in terms of a viral kind of mRNA vaccine as well. So when this thing came up, they were on the cusp of being ready and were able to roll it out very, very quickly. And it turns out it's actually a very, very good form of getting the body to recognize a foreign protein and make an autoantibody, because the AstraZeneca vaccine is a more traditional adenovirus vector, attenuated vaccine, which we've used for a long time, like, for example, for MMR and things like that. And as you're seeing, that sometimes the body doesn't quite recognize it as being as foreign. Whereas here, it is able to do that very easily, very quickly, very effectively, and safely, I should point out too. Yeah.
But when you say it's 94 efficacy, the best,
yes.
That means 6% of the population is still at risk?
Yes, but that's very low. 6% is excellent. When you get 94% on a test, you're like, wow, I did well.
I come from Indian family. That's not good enough. I get asked, where did those 6% go? Where did it go? And if you get 100, they say, what about the extra?
Yeah, this sort of comes back to, and we might have to do this at a later date, like with the flu vaccine. And that was, when we talk about some of these variants as well, the flu vaccine isn't 94%, right? And so, but also, they tinker with the flu vaccine each time. So here we are, we're rolling out this vaccine, and then all of a sudden people are talking about these mutant strains, and it's the UK strain, or it's this strain, and I'm thinking, well, I don't know. If I get the shot, am I okay against a strain that comes from Africa? Am I okay against a strain that comes from the UK? So,
this is a great unknown, but I can touch on it a little bit about where this is going. So just to go back to the flu issue before, that is an example of a vaccine that that we received that is around about 50, 55, 60%. And as you know, the efficacy varies every year. Now there's everyone knows there's an influenza A, there's influenza B. And a little bit of what we have to do is that we have to, the year before, make a educated guess about what dominant strain of influenza we think is going to be coming the next year. And let's say, hey, we think it's influenza A1. We will therefore have the vaccine against that mainly, and maybe a little bit of protection against the vaccine influenza B. But if it somehow switches and you get more B, those are the years when you see that the flu numbers are very, very high because the vaccine was not quite as effective, maybe even down in the 30, 40% range of effectiveness. Yeah. But again, it comes down to the bottom line that you really have to get the herd immunity up. You've got to get it into as many arms as possible. And if you do, it won't spread. So for example, if there's 3 of us here on this table and 2 of us have gotten the vaccine, then even if one of us gets exposed, the other 2 are unlikely to get sick. But if the 2 of us get exposed and the third one hasn't been vaccinated, it's almost certain she's going to get sick. So the more and more of us that get the vaccine, the less that spread is going to occur from person to person.
So are you a carrier even after you get the vaccine? You can be a carrier?
So that's a good question. Very briefly, there may be some data that suggests that after you get the vaccine, so here's 2 things that can happen. One thing is you get the vaccine and you may be a carrier for a short period of time, maybe a day or so. in terms of the fact that your system is ramping up a little bit. What can definitely happen is that you can get sick in that time, and maybe your sickness will be less severe, and maybe you'll think, oh, I've gotten vaccinated, therefore I'm not going to get sick, and you're a little bit less careful with the mask wearing, and you can then be a carrier and a spreader of the vaccine. Now, again, what we're saying is after the first shot, it's around about 80% effective. So 20% of people can get sick. And by the way, one of my people that I work with, one of our trainees, got the shot and is sick and has got real coronavirus. He's getting the fevers and whatever, and he's at home and thankfully recovering. But these kinds of things definitely can happen. After the first shot, there is a period of immunity that probably drops, like your chance of picking it up as compared to somebody who hasn't, it declines to about 50% more. And then eventually you end up with 90% after the second shot, and then 94.8 after 7 days after the second shot. So you're going from 80 to 95%. And with Moderna, it was 95.2 versus 94.8. So pretty much 95%. That's kind of where you're living after the 7 days after the second shot.
Can we but by the way, it's interesting the way that you put that, because for a moment there I was thinking, well, if the two of you get it, then I can be a free rider, right? I don't have to.
Yeah.
But it really doesn't work that way. I mean, if 75% of the nation gets the vaccine, that doesn't necessarily mean that the other 25% get to go, oh, good, thanks everybody for doing that. Now I won't get it because we've stamped it out. I would still have a greater chance of
sorry, that's a very good point to make. Yes, absolutely. You still have a chance of picking it up. It's just that the transmission should decline from person to person and make the likelihood of that interperson communication get less, because what you're hoping is that the people around you are not sick.
Yeah.
And I guess it just breaks that transmission.
We only have a minute left, but I guess my final question goes back to something that you had said in the beginning about wanting to roll things out quicker. Do we have enough people? I mean, if Gillette wants to have 5,000 people a day, do I have enough medical personnel to give 5,000 vaccines a day?
That's a good question. But you know what? It doesn't take a lot of training to do this. And I know that in other places, because I'm in touch with people in the UK, they are kind of getting any kind of healthcare workers, giving them a training and showing them how to put a jab in. So I think if you've got some healthcare training, we can very quickly ramp up that kind of personnel in order to be able to do it.
We took it right to the limit.
Yep. So finishing up, I want to thank Dr. Faisal Khan for coming. Such an important topic. As many of the viewers may not know, I did suffer the worst kind of consequence from this pandemic. I lost my uncle to COVID just a few weeks ago. Watched this horrible, horrible virus and its effects firsthand. And I couldn't thank you enough for sharing so much great information. And we will definitely continue this conversation. I don't think it's over, and I think there's a lot more information. And as we go forward trying to combat this virus, we're going to definitely have more conversation with Dr. Faisal Khan on this. Thank you so much for joining us. Join us again with Perspectives with Asima Silva.